today, okay? So I'm very happy for you to interact with me on the chat, and I'm very happy to change tact as we go because I think teaching should be about improvisation to match the requirements of the audience. And here we don't know the audience at the moment. So now we are at kind of somewhere in the middle of the brain on that axial. So an important landmark is here again. So here we have, first of all, going from outside to inside, you have this structure here, which is the Sylvian region, and this is the Sylvian fissure. Now, the Sylvian fissure is very important because around the Sylvian fissure, you have the arrangement of the perisylvian cortex and the insula, and that separates the frontal lobe from the temporal lobe behind. Okay, these are clear demarcations. All lobes are not clearly demarcated, but these are very clear. But also deep within, you have the arrangement of the gray matter nuclear structures. So this is the left side of the brain. This is the right side of this child's brain. So here we have the ventricles, the CSF-filled structures, the frontal horns, and you have abutting the frontal horn is the left caudate nucleus. Next to it is your putamen and the globus pallidus, which generally at this age appears a bit dark. And they constitute the lentiform nuclear complex. Together, we are looking at the basal ganglia structures, the left side and the right side. And then behind this are these thalamic nuclei, which look like one structure, but there are a cluster of nuclear structures. So thalamus also has a lot of gray and white matter. So that's the thalamus on the left, the thalamus on the right. Now, between the basal ganglia structures, the caudate and the lentiform, you have the anterior limb of the internal capsule. Now, remember, the anterior limb of the internal capsule is a white matter structure. It appears dark, and the anterior limb of the internal capsule essentially is transmitting the corticospinal tracts. So if we track this up and down, you would go all the way to the centrum semiovale region, where the corticospinal tracts are forming, going down through the anterior limb of the internal capsule, and then it basically does a turn. This is the posterior limb of the internal capsule out here. Important structures because any little infarction or tumor or something out there can cause quite a dense hemiplegia. Lower down, of course, as we keep going down, we encounter the brainstem structures and the corticospinal tract still appearing quite dark going down those brainstem structures all the way into the medulla and then into the spinal cord, which is the cervical spinal cord at that level. So lots of tracts. We have only looked at some amount of the corticospinal tract. And if I do come back, I will try to show you a few more tract-based imaging, which we can do now. Not always visible on conventional sequences, easily demarcatable, but it can be looked at from tractography, and we will look at a lot more of those white matter tracts. And the networks of the brain will be better understood when you know what the tracts look like. Now, I'm going to keep the anatomy quite simple. The first thing is to get the sequences out of the way. So we looked at the basal ganglia, the thalami, the ventricles, and some of the lobar separations using some clear demarcations. Here we are at a lower structure. So this is the midbrain, and these are the cruri of the midbrain. You've got the left cerebral peduncle, the right middle cerebral peduncle, and then arranged around the midbrain area is the amygdala, the hippocampus. And the hippocampus has a body, a head, a body, and a tail, and it basically hugs the midbrain and the brainstem structures around it. So that is why they're referred to as the seahorse if you look at their arrangement looking at each other. So the left hippocampal amygdala formation and the right side. Once again, you encounter these dark structures, and on this particular sequence, which you have correctly identified as the axial T2, the blood vessels will appear dark, and this is actually the middle cerebral artery, very important channel of supply to most of that middle cerebral artery territory in the hemispheres. So you can encounter a lot more information when you keep scrolling. Apart from the structure of the brain, you get vascular information as well. Now you're very much at the low level here, so you have got the temporal lobes on the two sides, and you're beginning to see the cerebellum in the back. And we will just kind of park the axial weighted sequence at that level. and bring in another sequence. So now, once again, before we move on, if the white matter appears dark, then it's a T2 weighted sequence, and it's an axial T2 when the CSF is bright. Let's compare that with this sequence. Here, the CSF is dark. Same patient, the CSF is dark. And the reason this patient had a scan was they wanted us to look at epileptogenic lesions in the context of generalized tonic-clonic seizures. Now, when we have generalized tonic-clonic seizures, by and large, unless there is a focal semiology from a radiological hat, I think maybe it's going to be a normal scan, which is what it's looking like. So it's a good normal to look at. So here we go. This is the white matter appearing bright compared to the previous sequence. The CSF is looking dark, and your gray matter actually appears like gray matter. It is dark gray. So cortical gray matter, as well as your caudate, the putamen, the thalamic nuclei, most of them appearing dark compared to the white matter. So what is this sequence? Any more answers? Remember, we will only learn from getting it right or getting it wrong, but committing to something. If we don't commit to something, then we will struggle. So good. So first of all, we know that this is not a T2-weighted sequence because we had a T2-weighted sequence before this. So this actually is a T1-weighted sequence. And you call it flare because I tried to mislead you by saying, I didn't mislead you, the CSF is looking dark. But if you only go with CSF, then you will fall in this trap instantly. And I will tell you why in a moment. You have to look at the white matter of the brain. If the white matter is bright, then this is a T1 weighted sequence. Okay? And this T1 weighted sequence has been done with a high resolution of imaging. So it's 1 millimeter slice thicknesses. And you can see a lot of anatomy here. And in fact, you are able to reconstruct this on different planes, which we will look at in a moment. But appreciate the T1 weighted sequence. Sorry, Dr. Yani, you have a question? No. Okay, if you have a question, just raise your hand and I can ask you all to unmute yourself and speak. So this is the T1 weighted sequence, and you will appreciate it by looking at the white matter structures. And the white matter structures are abundant in the brain at that particular age. Okay. So you called it flare, and the reason you called it flare was you fall in that instant trap of just looking at the CSF. I'm going to put the T1 and the flare sequences next to each other so you appreciate the differences very well. So here is the flare sequence. Now, mind you, the flare is also like the T2 because the white matter is dark. Okay, the white matter is dark on a flare sequence. The flare sequence, which stands for fluid attenuated inversion recovery, is the strongest sequence that gives you information about the degree and the extent of pathology in the brain because it really brings out the contrast between the gray and white matter structures. But on the flare sequence, the gray matter structures are bright compared to the white matter. On the T1, the white matter is bright. So white matter is bright on T1, white matter is dark on flare. The other thing to appreciate is that because it is fluid attenuated, essentially you have lost the signal. You've taken out the signal from all the CSF. And because you've taken out the signal from all the CSF, that is why you can pick up cortical lesions and small lesions everywhere. But just appreciate the CSF signal on the T1 compared to the flare weighted sequence. And you will agree with me that this is much, much darker compared to the T1 weighted sequence. Okay. Dr. Alzaid, do you have a question? No. All right. So This is the flare sequence where everything is quite dark compared to the T1 weighted sequence, which is not as dark, but appreciate the difference not just of CSF, but mostly the white matter that will make you get it right. So T1, flare, and all axial imaging at this point in time. So now I'm going to put a third dimension in there, which is going to be your T2 weighted sequence. So you get it all right in one go. Okay. We have looked at the sequence before, and I'm going to put the T2 weighted sequence here. So you never forget what the three look like. All right. So T2, white matter dark, CSF bright, flare, white matter still dark, CSF saturated out completely. This is nulled signal. T1, the white matter is bright. Is that useful for you to remember? Okay. And you might want to even take a screenshot of this to be able to remind yourself of what is T1, flare, and axial T2. So let's change gear. Now, these are your bread and butter sequences. You will see this in all the scans. You should always see a T1, T2, and flare in any patient for any kind of pathology, whether it is inflammatory, neoplastic, or epileptogenic, that you're trying to find a lesion which could be obscure, or even in the context of conditions like demyelination and leukodystrophy. This becomes a key element in terms of differentiating one from the other. Now we're going to change gear. Now, today I'm not going to tell you how these sequences are acquired. I'm just going to tell you how an MR image is acquired. So essentially, the scanner that one has is a strong magnetic field. It could be a 1.5 Tesla or a 3 Tesla scanner. And the stronger the magnetic field, the more power it has in terms of increasing the signal to the noise ratio. So you get a very good resolution. And the whole idea is to improve the contrast between the white matter and the gray matter structures of the brain. In that respect, when a patient is introduced into the scanner, imagine the human body. It is filled with water. 70% of our body is water, and that water is essentially H2O. So we have a lot of hydrogen ions in the body, a lot of protons. Going back to school physics, you will remember the protons are H plus molecules, and they are basically in constant motion, like spinning tops, and in very random motion to each other. So we are all magnetic fields walking around in a very random way. And that is why you're attracted to some people and repelled by some people. And there is a whole theory around electromagnetic connections between people. But when you put this electromagnetic body into a scanner, which is a very clean field of high magnetic strength, all these protons basically start aligning in order in terms of where the magnetic field is trying to take it. Now imagine a situation that we put a radio frequency pulse into that system, and all these protons of the human body will start aligning in a different way and start rotating in a different frequency because they have been agitated by the radio frequency pulse. And we give that for a particular time. We give that with some repetitions to make it very simple. And when we have done that, then these protons, like anybody who is disturbed, wants to go back to sleep, these protons will try to go back to their state of rest. And in that process, they give up some energy, because energy, as you will remember, is never lost or created. It's only converted from one form to another. And in that process of energy conversion, the energy that is emitted is basically captured on the system which we have with our MR technology in the form of pretty much filling a dot in a space. And these multiplicity of dots, the multiplicity of these signals that are emitted, create the image. Now we can have different tissue weightings, T1, flare, T2, just by either changing the radio frequency pulse or its angle or its duration or its repetition. So, multiple sequences have been generated since the advent of MR, and new sequences continue to be developed. But I can tell you that the core sequences have not changed. So, if you go back today, being able to identify your T1, T2, and flare confidently, then I think you are already on a winning streak. There are some other important sequences. So we will look at that, and then we will look at some sequences essentially in an immature brain. So I'm going to first of all show you the planes of imaging, and then I will show you the additional sequences. So now we are going back to a single picture here, and I'm going to ask you to name this plane. So what is this plane? Is it an axial, coronal, or sagittal plane? Let's get some answers on the chat room here. Exactly. So you are right, Dr. Yani, Dr. Hussein, and I'm sure everybody gets it at sagittal. And we are here at the level of the midline sagittal plane. Okay, this is exactly the midline. If you see my picture here, the thumbnail, the technology is so good that it tells you exactly where you're looking at, and it will tell you where you're left or right. Just your PAC systems will do that for you. But the midline sagittal of the brain is an important landmark because there are many, many monuments to look at here. So once again, I'm going to ask you what is the name of this structure. I'm going to describe the structure to you. You can see that this is bright on this T1 weighted sequence. Therefore, it is white matter. And because it is a sagittal cut you're looking at, you can almost imagine that this structure connects the two hemispheres of the brain. And for neurologists dealing with epilepsy, for instance, this is a very important structure. Correct, this is the corpus callosum. Dr. Abdullah got it perfectly spot on. Now we're looking at the corpus callosum in a sagittal. It looks the most eloquent on a sagittal plane. Okay. Now below that you have the fornix, which is also white matter structures. And then you have this round thing. Now you remember it is a sagittal cut. So you're looking at the massa intermedia out there. And then further down, you have the brainstem structures, midbrain, pons, medulla. I must tell you, it is a bit of an oversimplification to call the midbrain a part of the brainstem, but most textbooks have taught us that, so I'm going to stick to that for now. But I can tell you that strictly speaking and embryologically speaking, the brainstem is actually the pons and the medulla only. The midbrain actually develops from supratentorial descriptions. So it is actually every malformation of the brain that you see might have a combination with midbrain. Malformations of the brainstem generally allude to pons, medulla, and cerebellum, and they're not connected to the midbrain. So take that with a bit of salt that the midbrain is part of the brainstem. But our textbooks, our medical schools have taught us that, so we will stick to that, but it is not strictly correct. So here we have the midbrain, the pons, and the medulla, and you can see it looks like a bird. The beak of the bird is essentially this structure. Do you know what this structure might be? Because you're doing so well with anatomy right now. So I am hovering and I'm going to zoom it in onto this structure. On the sagittal, attached to the beak of the bird is this structure. What might this be? Correct. This is the mammillary body. Dr. Fahad got that right. And the mammillary body is a part of the hippocampal formation. Sorry, the hypothalamic formation, not hippocampus, hypothalamus. And this is important because you have the thalamic structures, you have the hypothalamus below it. Now, if you look further down, then yes, this is the sella. This is Dr. Jomar alluding to the sella turcica. And within the sella turcica, of course, we have the pituitary tissue sitting there, and you have the anterior pituitary, the posterior pituitary, which on the T1 weighted sequence appears like a bright spot. And you have the stalk of the pituitary gland. Coming up is the chiasm of the optic nerves kind of fusing together out there. So this is a very important arrangement. Optic nerve forming the optic chiasm, the hypothalamic structures, the mammillary body, the stalk of the pituitary, and the pituitary gland itself with its anterior and posterior. Now, why do you think the posterior pituitary appears bright on the T1 weighted sequence? Some of the elements that appear white on the T1 weighted sequences are fat. You can see that there is some fat tissue in the scalp out there which appears bright. The other things that appear bright would be protein, some forms of calcium, hemorrhage, and melanin can appear bright on the T1 weighted sequences as well. So, what is the content, Dr. Munira, in the posterior pituitary that makes it look bright? What is it trying to store? We know that the hormones that the hypothalamus is going to secrete are actually just transferred. It's a beautiful system of transport through the stalk, and they are basically stored as granules in the posterior pituitary bright area. And that is why it appears bright. And do you know what those hormones secreted by the hypothalamus are? Correct. And these granules essentially are, they have a good high content within them, and they are quite structured in a way that it gives you that particular signal. And it's a very important landmark. Losing the bright spot of the posterior pituitary actually implies either it is congenitally absent, or there is a situation of a condition referred to as diabetes insipidus, which would be a central form of diabetes insipidus where you lose that signal. It's very important to find it. On the midline sagittal, you also encounter other structures. You have the tectum of the midbrain, the tectal plate, and then, of course, you have the cerebellum behind. And this is also a good arrangement to show you the flow of CSF on the mid sagittal. So you have the aqueduct of Sylvius leading to the fourth ventricle. And you can see that the aqueduct leads on to the third ventricle, and so on and so forth. But the entire CSF system actually is in communication with each other, the intraventricular as well as the pericerebral CSF spaces. And that is why the intraventricular compartment in itself is the subarachnoid space of the brain. Now, if we move sideways from one side to another on the sagittal plane, we encounter the hippocampus again, and the hippocampus looks very elegant on the sagittal plane as well. So here, the hippocampus we know is a gray matter structure, and you have the head, the body, and the tail of the hippocampus lying in this format on one side. That is how it looks, and you have the amygdala in the front. On the sagittal, you also will be seeing the separation very nicely of the parietal from the occipital lobe. And this is the occipito parietal sulcus out there. And behind that is the occipital lobe. So some important structures on the sagittal plane. And the one plane I haven't shown to you is therefore the coronal plane, which gives you a different orientation to all the structures that we have seen so far. And the coronal plane is really useful for not just looking at the basal ganglia structures out there. You also have good views of the entire Swiss roll folding of the hippocampus, and then more so, you go back into the body and tail of the hippocampus on each side. Now, do you know what this structure is, which we were looking at from a sagittal perspective, which is connecting the two hemispheres and white matter, again, the corpus callosum? So the reason to ask you that question is to show you the corpus callosum in the three different planes. So you try to understand how these structures are arranged on the axial, the sagittal, and the coronal planes. Right. So we have looked at planes, we have looked at key sequences, and now I'm going to show you two other sequences which are also becoming relevant to every examination. One has been there for a long time, and it has its place in the sun for acute imaging, and it is this sequence. Now, it looks like a flare, does it not? Where you have the T2 dark, the CSF signal is saturated out. And essentially, it is a T2 weighted signal sequence. but it is highly sensitive to early interruptions to the Brownian motion of molecules and particles. And in this particular instance, this is referred to as the diffusion weighted imaging. Okay. Now, the way the diffusion weighted imaging is acquired is it gives you instantly two different parts. So you will see the scan and you'll see what is the sequence. You have this particular thing where the CSF looks bright, and then you keep scrolling through the same sequence and you encounter this where the CSF is saturated out. And diffusion weighted sequences are acquired on different magnetic field strengths. So it's called B0 or B1000, and some centers even do intermediate or higher values. But the whole idea of doing a diffusion weighted imaging is A, it looks like this, B, any early interruption to the Brownian motion of water, which is a random motion and easily facilitated movement that happens, becomes restricted in the context of an infarct, in the context of acute lots of edema, which would interrupt the flow of water molecules out there, which would be in the context of acute inflammation as well. Or you can have a tumor with a lot of packed cells. And in the context of high cytoplasmic ratios and packed cell density, you can get tumors which can restrict, like medulloblastomas, lymphomas, high grade tumors. And then, if you have a lot of calcification or hemorrhage sitting in one location, then also you can restrict your diffusion of molecules. So, this is a normal diffusion weighted imaging. The diffusion weighted imaging is a very important sequence. Also, it's a great sequence because it gives you as a free the apparent diffusion coefficient map. Now, all your scanning sets will have this thing, which is acquired as a byproduct of the diffusion. You don't have to scan the patient to get this. You get it off the system. And it's important to put the diffusion and the ADC, which is the apparent diffusion coefficient map, next to each other, because when we come back to part two and we start looking at some pathologies, or we might even have some pathologies today to show you, then you have to see what is truly restricted and not truly restricted. So if it is bright on the diffusion weighted sequence, it has to be dark on the ADC to call it truly restricted. So you will see me using the term ADC map. I'm going to put that in the chat, ADC map a lot. But this is only a byproduct of your diffusion weighted image. So you don't have to worry too much about scanning a patient to get this information. It is given free, but it is the most useful information that the diffusion gives you. And it becomes more and more relevant when we start looking at some tumors, because this particular sequence can be quantified. I can put a marker out there and I'm able to essentially get some values of what this might read. And the quantification that can be done on the go essentially helps us distinguish between true restriction and not true restriction, for instance. So, the last sequence on this data set and bread and butter sequences I would like to talk to you about is this sequence. Do you know what this is? Now, here you have kind of not got much clarity of the gray and white matter as such, but you do have very prominent blood vessels, beautifully shown. You've got arteries and you've got veins that are shown on the structure. Now, some centers would call that a gradient echo if they don't have this particular sequence. But nowadays, I think all scanners should have this. And you're right, this is a susceptibility weighted image. And different vendors call it differently. You can have Swan if you have, I think, a GE scanner, for instance. But it is susceptibility weighted image. And this is a normal susceptibility weighted scan. And with susceptibility weighted imaging, you get byproducts again. You get this thing, which is phase. For your level at the moment, don't get too concerned about this. And then you get different products out, but generally you're looking at the last of your susceptibility runs. And this can also be quantified using some quantitative susceptibility mapping techniques that are now available. So why is it useful? Now, It's a very pure magnetic field that the scanner gives you, very strong and very pure. Excellent. Any impurity in that field throws in a big artifact, whether it is a nail passing across or a fleck of calcification, whether it is paramagnetic or diamagnetic substances. So this is very, very sensitive to picking up hemorrhage and blood products, particularly heme degradation products. It is also sensitive in terms of picking up calcification. And I say that with a little bit of hesitation because if it's a large fleck of calcification, yes, you can see it. Definitely of the MR sequences, this is the most sensitive for calcification as well. But for faint dots of calcification, I still rely on the CT scan. I'll be honest about that. But for blood and heme degradation products, this is extremely sensitive. The susceptibility weighted imaging shows you a lot more anatomy than we were aware of. So we knew that we had the deep venous system. You can see the internal cerebral veins. You have the dural venous system and you have the cortical veins. But there is also a whole mesh of transmedullary veins going across. Of course, the arterial system here also is well depicted. That means when there is an acute stroke kind of situation where there is swelling in the brain or there is a delayed venous return, you will start encountering abnormalities, and just comparing the left to the right will help you in a significant way. So that is susceptibility weighted imaging, and these are all interplay of different sequences that we have been talking about today. Now, I did promise you that I was going to confuse you a little bit by bringing in an early brain scan from, say, a neonate. And this is my next scan here, just to show you the normal sequences. And this child was scanned for clinical indication of suspect neurocutaneous melanosis. Okay. Now, first of all, before you start seeing anything, try to remember the picture I showed to you about the T2, T1, and flare. Okay. And all the rules kind of work in that very well. Now we are going to look at this picture here. So we said that the white matter is dark on a T2 weighted sequence, correct? Are you still seeing my screen, by the way, this particular screen? Or I should share the right screen again. Hold on. This is the right screen, correct. So in here, you have the T2 weighted sequence. Now, my rules have gone completely opposite. Here, the white matter is bright and the gray matter is gray as expected. But that doesn't make it a T1 weighted sequence. This is only the context of a neonate. As myelin matures, the signal of the white matter and the gray matter shifts drastically. In a neonate, you get absolute reversal of signals. So this is your T2 weighted sequence. The CSF is still bright. The white matter is bright. Compare that with a T1 weighted sequence. On the T1 weighted sequence, in this period of life, your white matter is dark. So it flips. Don't get confused. Just remember that everything you see in a mature brain is flipped in a neonate. If you think about myelin, there is water and there is fat in the myelin. When children are born, they have a lot of water in the brain. And when that water is present, the brain is very well hydrated. And because of the water content of the white matter, you get dark signal on the T1 and you get bright signal on the T2 in the white matter. As we are born and as we mature, the white matter starts losing its water. The brain starts dehydrating, in simple words. The relative proportion of the fat in the white matter, in the myelin, so to say, goes up. So water comes down, lipids go up. And in that context, you start seeing more of the signal from lipid as the brain matures. And I did tell you that fat had a high signal on T1, and therefore the white matter becomes bright on T1 as individuals mature. So the whole principle is different in neonates, and it is to do with the immaturity of the white matter. And as it matures, things start looking good. So therefore, when we go back to the neonatal brain, and it looks quite bright, and we do two T2 runs generally. Some centers do it, some don't. We do it. This is the first echo, second echo. The whole idea is to try and improve the conspicuity between the gray and white matter. And when you look at a structure like this, for instance, in a 4-week-old, this is the posterior limb of the internal capsule, which is myelinated. And it's a good way to show you white matter that is not myelinated and white matter that is myelinated. And over time, therefore, the white matter starts becoming all grayed out like this, like we saw when we started our discussions today. And so, given the shift in contrast, we tend not to do a flare sequence for around up to 1 year of life. You won't easily see a flare sequence on many, many cases. And that is because it is going to be very bright. Flare is very, very sensitive to the presence of water and fluid in the brain. But it has its role, particularly in the context of infections and trauma, etc., that we still do a flare, but it's more difficult to interpret. So this is a neonate. I wanted to show it to you to tell you that there is a flip in the signal of the gray and white matter structures in the neonate. Now, there is a process of windowing where we can even accentuate the differentiation of these quite well, and that's your neonatal brain. Of course, the other sequences like diffusion and all look fairly similar. That is a diffusion weighted sequence in a neonate, something like this looks similar. You've got susceptibility weighted sequences, also looks not too bad. But in the context of a neonate, remember that your T1 and T2 will flip around. And we don't easily do a flare on the neonates unless really required. So as a dictum, white matter appears to complete its maturation on T1 weighted sequences by the age of 1, on T2 weighted sequences by the age of 2.5, and on flare sequences, the maturity of white matter, like an adult kind of white matter, would be by the age of 4 to 5 even. So it takes a longer time for maturation to show on our MRI scans. Good. We have looked at many things which are normal here. And I'm going to conclude in the next 9 minutes by showing you some malformations of the brain. So when we do come, and if you want me back next time, then at least we would have got some background material sorted. I am going to share the screen, and I'm going to just give you a little bit about speaking the same language. I believe you're still seeing my screen, right? Correct. Thank you, Dr. Bill. Crystal. So one message, and every time I see you all, I'm going to leave you all with some key messages. Speaking the same language. Now, this takes you into the depths of pediatric neuroradiology. We talked about epilepsy, etc. I'm just going to show you a spectrum of cortical malformations and what they mean. Terms that have to be defined. So you saw a normal brain in a neonate, and you saw a normal brain in an older child, much older child, but you saw the two ends of normality. Lissencephaly. The term lissencephaly means a smooth brain. So you look at the outside, it's a smooth brain. Not only do you have the loss of the sulcal folds that you had, so to speak, you also have a thickened cortex. So we are now beginning to see malformations of cortical development. Malformations of cortical development can start right from the induction of neurons around the germinal matrix all the way as they migrate to form the cortex. So they can get arrested as heterotopias, or they can get to the cortex and get disorganized. This is a thickened cortex with abnormal gyration, and it can range from agyria, you can have a completely smooth brain, to oligogyria. So you can see that there are some depths here. This would be called oligogyria. That is lissencephaly. And if I were to tell you that the cortex actually starts here and goes all the way across this very, very thick cortex. The next term is a simplified gyral pattern, and you will use this term simplified gyral pattern where the cortical thickness appears normal, but there is a reduction in the number of gyri and there are some shallow sulci. So it's a bit like this is not fully sulcated brain. Cortical thickness looks all right, but the number of gyri is still less compared to what we should expect. Now, the compared to what we should expect will come from keeping a normal next to it. And the more you look into scans, the more you look at normals, getting the handle right will help you enable you to describe what is abnormal. The next term is a term that you will start seeing a lot more in the literature, and it's a bit of a wastebasket term. If it's not lissencephaly, if it's not heterotopia, if it's not polymicrogyria, then what is it? It is not normal. So here again, the cortical thickness is normal, and the number of gyri is not less. There is lots of gyral formation, but they are abnormal with abnormalities and significant variations in the sulcal depths. This is a harder one. This is the hardest malformation to pick up. And it is a morphology. Remember, it may not even have a genetic basis, but it is a morphology that you're describing. The term was initially used in the context of tubulinopathies, but the term has been used in certain other spectrum of disorders as well. So you have abnormalities of sulcal depth and orientation. So some of them pointing in this way, some pointing that way. Smooth cortical surface and narrow gyri separated by abnormal deep or shallow sulci. So very disordered kind of arrangement, but not typically heterotopia or polymicrogyria. Now, this is more elegant, the subcortical band heterotopia. Once again, you have a very thick cortex here. The cortex starts here and ends all the way there. And these are neurons which were marching like an army to form the cortex from the lining of the ventricles, but they were arrested for whatever reason, mostly a genetic reason in this case. It could be an acquired reason as well, but this is too uniform, too smooth, and too symmetrical to say acquired. So this is your T1 weighted sequence. You know that the white matter is bright. This is a T2 weighted sequence, and this is not a neonate we're talking about. And you can appreciate that the gray matter structures, which were destined to form the cortex, did never form the cortex. So arrested neuronal migration, you're noting the pachygyria, and in between the folds of the cortex and this arrested migration, you have the cell sparse zone. It looks like as if there is normal tissue, but it is not normal tissue. The cortical thickness starts there and ends there. This is subcortical band heterotopia, and different forms of heterotopia have been described since. Like, for instance, this, which is a ribbon heterotopia, still the same context that the neurons fail to migrate. And remember that in heterotopias, the cortex is not going to be normal either, because you can see that this is a very abnormal looking cortex, but the cortex actually is this whole thing. Ribbon heterotopia, described only in one mutation, apparently a normal finding in starfish. You can see why a starfish might need ribbon heterotopia with its 5 arms or whatever, requiring some neuronal support. And then we will look at a lot more of these entities, which are called the focal cortical dysplasias. Sometimes all they have is a blurring of the gray-white difference, but at times you can encounter that tail of signal going down, and that is referred to as a focal cortical dysplasia type 2A. But this is a changing goalpost. The more important thing is that focal cortical dysplasias may be associated with other abnormalities like tumors. And you guys are clinicians, so you will understand the ILAE classification better than a radiologist. And then we talked about heterotopias. This is the other context. This is right at the beginning of induction when the neurons have failed to leave their germinal matrix line or the induction zone. And this is failure of induction, basically. So, right at the beginning, and this is bilateral periventricular nodular heterotopia. Remember, all these entities can have genetic or non genetic basis as well. But when it is very symmetrical and so well distributed, we try to screen them for significant genetic mutations before we rest the case. And then we have our quintessential polymicrogyria, which is multiple small gyri. You can appreciate that here. They're folded together. Polymicrogyria can look like many different things, but the basic principles are that they can be symmetric or asymmetric, but they are multiple small gyri clustered together. And these are very typical locations for polymicrogyria. This is not normal folding. You can call it normal folding posteriorly, but this is not normal folding. Now, when we talk about polymicrogyria, we have the entity of cobblestone polymicrogyria complex. Traditionally, these used to be distinguishable differently, but more recently, we have managed to say that there is a continuum because when you look very closely to the cortex, it looks like over-convoluted, but essentially they have a smooth outer contour. By and large, they have white matter subcortical signal abnormality as well. And this is cobblestone. Cobblestone was typically described in the dystroglycanopathies and very rarely would be described with other entities. So when you encounter cobblestone, look at the white matter and look at the cortical upper and inner folding. Finally, you will encounter entities like hemimegalencephaly, which is more of a unilateral problem, but you will have all sorts of things in hemimegalencephaly. Apart from the overgrowth, you will see areas that look like polymicrogyria, areas that look like lissencephaly, areas that look like simplified gyral patterns. You can have a combination of malformations in the same case. The last entity, which is not typically a genetic kind of entity, is schizencephaly. It's clefting of the brain, and you have clefts which could be communicating with the ventricles or not, but the cleftings are generally accrued to as some kind of a vascular insult in early life. And the current thinking is that these are lined by dystrophic polymicrogyria-like cortex. So you will have a cortical malformation lining a cleft, schizencephaly. That's really it from the terminology's point of view today. We're going to stop our session. If you have any questions right now, or even if you have questions later, feel free to reach out. But this is our hour done for today. And I think we've had enough information explosion happening, so we need time to reflect and assimilate.
Thank you so much, Dr. Kish, for your amazing lecture today. The floor is open for the audience. Anyone wants to ask any question?
I will leave my email ID in case you all have any questions or have any cases that you all want discussions on. But you can also reach us on social media. I think Dr. Saad is very active on Twitter, and that's the handle. Very, very good to connect with you all today. Thank you very much.
Thank you so much, Dr. Kish, and looking forward to meet you again, inshallah, soon.
Next time we meet, we shall be looking only at pathologies, but please remember your T1, T2 flares, diffusion SWI, and what they look like in older children and younger children. Okay?
Thank you so much.
Thank you very much. Bye bye.